as already noted in what we talked about in the MIAP project, it involved a whole team approach, which was inclusive of the community pharmacists, our hospital pharmacists and the clinical advisory pharmacists, so in addition to the medical and nursing colleagues. And I also completed my internship. I have a background in community pharmacy and I worked in that context for 12 years prior to going to the dark side, so I can claim a little bit of insight. And since completing the MIAP project, I've also become registered, like my colleague over here, in the Pharmacist prescriber scope of practice. And so I have a weekly medicines management clinic and a repeat prescribing clinic at a general practice in Wanganui. And in this practice, I've gained a new appreciation of the challenges faced by prescribers when we start to deprescribe and implement changes to the recommendations that clinical advisory pharmacists make in their reviews. So that's where the rubber hits the road, and it's a lot different when you're on the other side of the review. And although PHARMAC pays for us to organise and speak at these seminars, it has no editorial influence over what we say and any content. And so what I'm going to present is based on my own practice, and any mistakes or omissions or errors are my own. And I'm going to present a memorable MIAP, the multi-interventional approach to polypharmacy case, who in my view became a kind of a poster girl for the pilot, and because she highlights lots of aspects of managing polypharmacy, not only from the pharmacist's perspective but also the other stakeholders. So before we get started, a little bit of trivia. Which country has the highest rate per capita consumption of bananas globally? And I don't have any chocolate fish. New Zealand, yeah. And how many bananas per capita per week? Goodness. Yep, we import about 18 kilograms of bananas for every person each year, or about 2 bananas each week. Yeah. And this does have some relevance to the case. So another question, getting more onto the topic. So what would be your ultimate disease, if you had to think of one? So as a pharmacist who spends their whole day dealing with drugs in one way or another, for me polypharmacy is the ultimate disease. And some experts in the JAMA in 1998 stated that if medication-related problems were ranked as a disease, it would be between the 4th and 6th leading cause of death in the USA. And polypharmacy has been described as an age-related geriatric syndrome that is a significant predictor of malnutrition, hospitalisation and nursing home placement. It impairs mobility and leads to morbidity and death. So returning to the case, Colleen, who was MIAP patient number 24, Colleen's family have given me permission to use her name in this presentation. And she was a 77-year-old lady who lived with her daughter and her daughter's family in suburban Wanganui. And the family had basically fronted up at the community pharmacy and sought help from the community pharmacist, who they had a really good relationship with, due to increasing struggles trying to get Colleen to take her medicine every day. And so this was the referral, and up until this point the community pharmacy had been providing Colleen's prescriptions dispensed in weekly blister packs. And after her daughter approached the pharmacist to see if something could be done to alleviate the problem and or assist them, the pharmacist contacted the GP's practice nurse highlighting the issue, and the practice nurse flicked off a referral out of MedTech to us for a medication review. And thinking a bit more about the referral itself does raise the issue of case finding and responding to polypharmacy in primary care, and we've talked a bit around this morning already. And in this instance, the case actually found us, and we responded to a need highlighted by the family on behalf of the patient. Anecdotally, at least, most of our referrals for assistance with medication reviews are reactive responses to adverse medicines-related events. For example, in patients who are frequent fallers or frequently attend ED, so rather than proactive, like going through your your BPAC audit or whatever, and approaching those cases and dealing with them proactively. We're in reactive mode purely because of the time and a whole lot of other barriers. Following the end of the MIAP pilot, we ran the Health Quality and Safety Commission Polypharmacy query in a practice of about 12,000 patients, and it resulted in a list containing hundreds of people on 11 plus medicines, with huge implications, as people have commented already, for how we manage this in practice. And at the time, our efforts at developing a more systematic and proactive approach to addressing polypharmacy using this list really fell at the first hurdle. And while there was certainly some interest that had been engendered by the MIAP and the SMAS pilot, finding capacity amongst already overworked clinicians and amongst the clamour of all the competing projects and performance indicators proved impossible, and our service remains to this day in reactive mode, so we're still responding to referrals that are problems that have already happened rather than preempting them. Nevertheless, if you do want to profile your polypharmacy patients, you can use the Find My Patients tool in MedTech 32, and you can also apply, it doesn't show it there, but you can apply alerts and recalls to these patients, so if you do want to get proactive. And as Marion's already mentioned, the BPAC polypharmacy audit attracts MOPS points for review activity or audit credits for GPs, so that's like a bit of a carrot for anyone wanting to do that. So back to Colleen and responding to her referral. The clinical advisory pharmacist response to this type of referral is a medication review, and we've already alluded to the fact that it's a term and a concept which means different things to different people. And for us, a medication review is a quite structured process with several steps, including data gathering, synthesis of a management plan, and communicating the plan. And this usually occurs over a period of a week or two, and it involves various stakeholders depending on the case and the complexity. So the first step of gathering data and assessment in Colleen's case involved several aspects. So we had the referral letter, which had a little bit of information on it, and it had a bit of a steer about what the patient or the family wanted to get out of the process. And then a lot of we also have access to the secondary care clinical portal for a review of clinic letters and other information. So what wasn't on the referral, we can, in our area, get into the clinical portal and have a look for things there. But for us, the key processes of assessment are the home visit and the medicines reconciliation, and clarifying what the patient wants out of the process. And the home visit is probably, Ian and I think Marion also have alluded to this, are really important to get context and to actually see what people are doing with their medicines and how they're taking them and what's going on around them. And you don't have it now, having sat in a medicines management clinic in a GP practice. When I do my consults, the first thing I ask them is, what are you actually taking? And people invariably don't bring their medicines to the consult, so you're really spending quite a lot of time trying to put a puzzle together. It's very difficult. So just talking a little bit about medicines reconciliation, it's a globally recognised as the gold standard process for determining an accurate list of a patient's current medication, including name, dosage, frequency and route, and includes complementary and alternative medicines. And this is the form that we use in Whanganui Hospital, but we as clinical advisory pharmacists in primary care, we use the same form when we're doing a medicines reconciliation. And the usual context where it's applied is, according to the defined standard, is on admission to hospital. But an accurate list of what the patient is actually taking is actually critical to making safe prescribing decisions in any context. And it's really good for highlighting adverse drug reactions or non or suboptimal adherence. And it's also good for identifying changes and errors and additions. And for example, where multiple prescribers are involved or after discharge from hospital at the general practice. And this is what I do quite a lot in my prescribing practices. When people come after they've been discharged, I'll do a medicines reconciliation back at the general practice, and then I can update the medication list and make some notes around that, which is helpful for the rest of the team. So, believe it or not, these are pictures of what I call the low-hanging fruit in terms of dealing with polypharmacy, and these are drugs that I've collected. Like when we do home visits, we pick up medicines that people no longer want, and these are old photos, but they kind of illustrate quite graphically, I think, when we prescribe things, we don't really know what happens to them, and I don't know, probably the pharmacists in the room, that bag there is full of what drug? What are those? What are those? Yeah, we call it vitamin O. Yeah, so omeprazole, and that was by far and away. And this is an outer of paracetamol, so 1440 or something paracetamol. And there's antibiotics and oxazepam, and that's Augmentin, and this is actually a patient that I went to see last week on Thursday morning, and this is the bag full that I got back just from one visit. So these are all paracetamol, these are tramadol, there's some Serotype Acuhalers there, which are actually quite expensive, and about 12 or 15 tubes of permethicor ointment. So once as much information as possible is gathered about from the patient and the objective has been clarified, what we do is synthesise all of that information into a medicines management plan. And the literature does describe a number of different strategies and related tools for assessing medicine's appropriateness. The tools that include explicit criteria for detection include the BEARS and the stop-start, and these usually comprise lists of drugs or drug classes and doses that are known to cause harmful effects in older people. And the advantage of explicit criteria is that they can be applied with little or no clinical judgment. However, they don't address the burden of comorbidity, as we've already alluded to, frequently found in older people, and they don't take into account patient preferences and previously unsuccessful treatment approaches. So a drug is deemed potentially inappropriate based on the properties of the drug itself. And this contrasts with the implicit criteria tools, which are not drug or disease specific, and they focus on the individual patient and patient factors to assess appropriateness or otherwise. And they consequently do rely on clinical judgment and knowledge. And in practice, we use a tool developed by our guru, Dr. Linda Bryant, called Please Do. And this links medication to the diagnoses or clinical problems, and it contextualises to the individual patient. So this is the Please Do framework. As well as the age of the patient, it's important to consider frailty in the assessment of likely medication-related benefit for individual patients, and to bear in mind that frailty is actually a diagnosis that has a poorer prognosis than most cancers. So for an average life expectancy for a 70-year-old frail European woman is less than 2 years, and the same for a 70-year-old frail European man is less than 1 year. So and in this context, as we've already mentioned, the focus is on quality of life and not on prevention of future illness. And many medicines that are good practice in younger or fit elderly people are more likely to cause more harm than good in a frail person. And the other thing to remember is that the patient's life expectancy may actually be shorter than the time needed to realise benefit from any specific medicine prescribed. So when we're talking about 2 years or whatever for vitamin D, if they're not going to live 2 years, then is it really a good idea for them to be taking it? So I've broken all the rules, I think, of PowerPoint and put far too much information on the slide, but this tried to summarise the assessment and synthesis steps in Colleen's case, and this is what it looked like. And Colleen had a major motorcycle accident in 1984. The furosemide, it's up there with musculoskeletal because it was originally prescribed to reduce swelling in the left ankle, and following all of the surgeries, and the potassium was related to being on the furosemide. During the assessment, I couldn't elicit any reports of pain or uncontrolled pain. However, the family noted that the paracetamol tablets were among the most difficult doses to get into Colleen, and at the time they were and I think they still are, quite uncoated. They're not the nice shiny Panadols that slip down. They're kind of dry, quite large tablets, and they were kind of fighting with her to get those in. Adherence was patchy overall, and incontinence was highlighted as an issue, as well as challenges maintaining fluid intake. And at the assessment interview, it also uncovered the fact that Colleen was obsessed with bananas, and she would eat up to 5 in one day, and the family related how they actually had to hide the bananas so she couldn't find them, because she would just literally eat them all up. And so I assessed that the potassium was probably actually a relatively homeopathic. So in relation to the cardiac medication, in 2005, Colleen had presented to ED with chest pain, and this was investigated as they do in ED with serial troponins, and she subsequently went on to have an exercise ECG, which failed to demonstrate myocardial ischemia, but in the letter it actually had, but we cannot rule it out. During the assessment interview, the family related that that episode had occurred around the time when Colleen's late husband was beginning to become unwell, and at that stage she was caring for him, and she was actually suffering quite a lot of situational anxiety around her husband's unwellness and what she was going to do. And it was the family's firmly held belief that it was this context that was actually responsible for her chest pain and her presentation to ED, and the family history was negative for cardiovascular disease. So while the related medication looked like a secondary prevention context, a primary prevent was never established, so there was a bit of uncertainty there. And in terms of diet, the carers at the assessment reported that Colleen had a supervised diet, and she'd been putting on weight, and she had no signs of indigestion. So when we applied our Please Do framework in this case, it helps to identify the targets for optimising medicines, but also highlight some challenges. And that includes that even after a detailed process of discovery and data gathering, there's still big gaps in the information on which we have to make decisions. And another challenge is the uncertainty around estimating the benefits, as Ian's already talked about, in individual patients whose characteristics differ from trial populations. For example, thinking about, are the benefits of vitamin D supplementation in terms of fracture prevention the same for a free-ranging elderly person as they are for frail patients that are in rest homes, where most of the trial data sits. And also that realising the potential benefit of preventative medicines, as I said, such as statins, it assumes optimal adherence over the time frame required for the benefit to accrue, and this wasn't the case for Colleen. So people have been struggling to get pills into her, so she wasn't taking the statin every day for 3 years or whatever's required for the benefit. And so even in dementia, even gleaning an idea of what benefit symptomatic medicine is having for a person, for example, like trying to figure out if the analgesia is actually helping for pain control or the omeprazole for indigestion, if that was what it was indicated for. So in any case, her medicines management plan, which we'll come back to a bit in more detail a bit later, was negotiated with the family, and this is what we communicated back to the GP and the practice nurse. And at this point, from the clinical advisory pharmacist perspective, the intervention is complete. So we're all job done. But for the picture looks a little bit different from the other stakeholders' perspective. And to achieve the family's goal of improving Colleen's quality of life by reducing medication, the recommendations and plans still have to be implemented. And this in itself is a process containing a series of steps. And another sidebar, at this point is the idea that medication review, in inverted commas, becomes some kind of indicator of better medicines management, because the reality is at this point, although the patient has had a medication review, nothing's actually changed. So to realise the patient's objective, some medicines have to be stopped or deprescribing has to occur. And Philippe Pinel, who's widely considered to be the father of modern psychiatry, alluded to deprescribing actually back in 1801 in the context of psychiatry in his treatise on insanity. And it's become an area of intense interest and research activity in the last few years. And there is actually heaps of evidence. I've just put a few papers up there which I found interesting with some of the key authors and researchers, and there's heaps more. And deprescribing is the process of tapering and stopping drugs with the goal of managing polypharmacy and improving outcomes. And related research is appearing in the journals every week. And just over a month ago, I even read an abstract of a qualitative study of an instrument to measure patients' attitudes and experience of deprescribing. So there's lots of different perspectives and aspects of deprescribing that people are starting to research. And the first 3 papers show that various types of medicines can be successfully withdrawn with little or no harm to the patient. And the last 2 are actually systematic reviews of all the deprescribing trials, and they summarise the RCTs and the observational studies involving deprescribing interventions. So they're quite, they're quite good papers to get a kind of a grip on what is out there. And the systematic reviews do suggest that deprescribing is beneficial, and the evidence is increasingly accumulating in terms of stopping particular medicines, all of which helps to give us more confidence when we make these kind of decisions. But it is acknowledged that while the literature is starting to support those decisions, it very much lacks evidence on how that guides us on how to stop the drugs. Until we do get some more specific guidance about how to taper, I follow the evidence or the sort of adage from Tim Mayling, who was involved in the MIAP, and he says taper everything unless it's obviously unnecessary to do so, or that stopping something, or you're stopping something due to an adverse effect. So that's kind of a rule that I keep in my head. And even though Philippe Pinel alluded to the barriers of deprescribing around 200 years ago, there's many challenges to deprescribing remaining in daily practice. And anecdotally, the most often cited challenge or criticism we as clinical pharmacists face is from frustrated GPs, and it relates to the lack of time available to read and process the recommendations in our reviews. And the time spent discussing reviews with clinical pharmacists and processing the recommendations inevitably is time that they cannot spend seeing paying patients or completing other priorities. And this is the most common reason why implementation of our plans doesn't actually occur. Having said that, our experience supported by the results of the SMAS part of the MIAP pilot is while the GP or the prescriber or the deprescriber ultimately gives effect to the changes by signing the prescription, the decisions by and large have been worked up during the medication review, and the actual practical aspects of implementation are coordinated by other members of the team. So in Colleen's case, it was the practice nurse that actually printed the scripts, and obviously the community pharmacist is the one that has to dispense the changes and all that sort of thing. The process of shared decision making, which is also another area of intense and growing research, effectively shares the responsibility for decision and the outcome with the patient, and this reduces the uncertainty and the fear of harmful consequences, which are often cited barriers to stopping medicines. And as well as helping to manage polypharmacy, shared decision making can prevent it in the first place, so when we're starting to prescribe. So back to Colleen's plan, it actually included 6 deprescribing decisions for the GP to authorise. And stopping the homeopathic potassium supplement and the multivitamin were easy decisions in view of Colleen's obsession with eating bananas and her supervised diet. And the furosemide and the omeprazole were being prescribed for symptoms, so tapering schedules with objective monitoring criteria were suggested, although, as I've already said, in the context of dementia, monitoring discontinuation effects can be quite tricky. So the statin and the aspirin decisions were the most probably the most complicated, and the fear of stopping the statin is, what if I stop it next week and she has a heart attack and dies? It was mitigated by sharing that uncertainty with the family, who, because of the context around Colleen having been very anxious at the time when she had the chest pain and the equivocal ECGs, when they heard all of that information in the assessment process, they ultimately made the value judgment to stop those drugs during the synthesis of the plan. So at the end of the day, for Colleen, it wasn't the GP's decision to stop it. So, and even if you look at the plan, even if only the easy decisions had been implemented, there would have been a significant reduction in her medication, so that where there's unreconciled uncertainty, you can always defer deprescribing decisions until more information is available or the clinical situation changes. So if the result of prescribing is a prescription, do we call the result of deprescribing a deprescription? What do we think? In any case, once we've got the deprescription, the final very important step remained for Colleen to realise her goal of minimum medicine, and it's the community pharmacist who, practically speaking, implements medicines management plans by dispensing prescriptions and for ongoing adherence support. And things to be aware of is that this can also be complex and fraught with risk if communication between the stakeholders isn't on point, and patients also incur significant extra cost at the community pharmacy as well as at the general practice as a result of synchronisation of prescriptions, especially if it requires a change to compliance packaging. So simple things like trying to coordinate your dose reductions with blister packing cycles can reduce that cost and complexity. So the outcome for Colleen was, at 6 months, her polypharmacy was cured, depending on your definition, and certainly in terms of Colleen's and her family's, what they wanted. Her goal in terms of her medication had been realised, and most importantly, they reported that Colleen was settled and happy, and they were no longer having daily fights getting pills into her, and that was resulting in much reduced stress in the household and improved quality of life for Colleen and for the wider family. So in summary, managing polypharmacy, or what pharmacists are starting to call a medicines optimisation, is a complex system of processes which involves multidisciplinary teams of clinicians, as well as patients and their families in collaboration. And from a pharmacy perspective, clinical advisory pharmacists are involved in review and development of medicines management plans. Community pharmacists are involved in implementing the plans and supporting adherence. And there's a small but growing number of pharmacist prescribers involved in deprescribing and monitoring changes. But regardless of our specific roles in the process, we're collectively responsible for helping to optimise patients' medication. And these are my take-home tips. So if you remember nothing else, I'd like you to perhaps remember these, and hopefully they'll help you. And they're a mixture of the lessons that I've learnt, sometimes the hard way, and the wise advice of some experts. Firstly, never neglect the med-rec, because this frequently identifies prescribed medicines, as I've put up, that the patient isn't taking, and which are the very easiest medicines to stop. And also because it's really impossible to make good prescribing decisions if you firstly don't know exactly what the patient's putting in their mouth. Secondly, Chris Cameron, who's a clinical pharmacologist at Wellington Hospital, Her sage piece of advice is to never change a winning formula. And this is especially true in conditions which are quite brittle and hard to manage, such as congestive heart failure, Parkinson's disease and epilepsy, and also in complex mental health situations. And thirdly, as I mentioned earlier, until there's more evidence that tells us exactly how to stop medicines, Professor Tim Mailing's advice is to taper everything unless tapering's obviously unnecessary or there's a compelling reason to do so. And finally, whenever changes are made, they must be documented carefully and communicated well. And unfortunately, we have weekly anecdotes about good deprescribing and, in fact, good prescribing decisions that are not implemented or are undone because of unclear communication or communication breakdowns between different stakeholders. So, in a postscript to the case, Colleen died following completion of the MIAP project shortly before her 80th birthday and approximately 2 years after the original MIAP polypharmacy intervention. And following completion of MIAP and full implementation of her plan, she became a low maintenance patient from the perspective of her healthcare team. So she had, her polypharmacy was cured. She had no more blood tests or investigations following that intervention, and she never presented again to ED. Obviously, her family continued to get prescriptions from the GP, but she died at home and she had a very good life to the end, according to the family. And even today, when I eat bananas, I often think of Colleen.